Please note that Dizzy Directors is intended for educational and informational purposes only and does not provide medical or any professional advice. Dizzy Directors is not substitute for professional medical advice, diagnosis, or treatment. Consult your healthcare professional for any medical or other related questions or concerns. All right, hello everyone. Welcome to another episode of Dizzy Directors. My name is Lauren Clark.
My name is Tori Moser.
And today we have Dr. Bianca, which is like really, really cool. And Dr. Bianca is, I believe if I'm getting this right, and you can totally correct me, is a chiropractic neurologist?
Yes, I'm a chiropractic neurologist and a functional medicine practitioner.
I mean, I kind of just want to get into that like real quick because I've never heard of a chiropractic neurologist. And I told Tori and we were like, what is that? So just if you could explain kind of what it is, what you do, how you also got into it, because I'm sure not a lot of people know what it is. So if you could just explain kind of what you do and how you got into it.
Yeah, for sure. So my doctoral training is in chiropractic, and my postdoctoral training is in clinical neuroscience and functional neurology and functional medicine. So what chiropractic neurology is, or functional neurology is we're taking the parameters of clinical neuroscience and we're narrowing them down. And when we narrow them down, we're not only evaluating, what is going on with the nervous system, but also how is it overall functioning? And the various systems that are involved with the nervous system and what the nervous system ultimately has control over. And so it's based on the premise of neuroplasticity, that the brain is the only organ that can change its own function in real time. And so when we understand how it's functioning, or the areas that aren't functioning well, and we target those with very specific rehabilitation exercises or activities, or you name it, we can correct that dysfunction and improve someone's functionality and improve their symptoms and so forth.
I mean, that's great. That's cool. I'm kind of just fathomed because like I was doing research on you beforehand. I just think it's so cool of like what you do, and I, kind of been reposting what you guys do. But I mean, specifically with like what is the practice that you work at do? Like I know it's helping out people in a holistic way with POTS and things like that, but what does the practice specifically do?
Yeah, so I'm a part of Carolina Functional Neurology Center. So we have 2 locations at this time, in Charlotte and in Raleigh, North Carolina. And what we do is, one, and I know we're going to get into this, and specifically with patients and especially with dizziness of all sorts of what cause that, but we are examining our patients and understanding what is going on with their nervous system and why are they having their symptoms. Is it solely just the nervous system? Are there other systems in the body at play? And we are addressing that with very specific rehab, very, very specific to their system and their system only. And we utilize, obviously, so that's more active stuff in the office. We utilize hyperbarics. We utilize infrared and red light therapy. We utilize EMF therapy. We have a lot of tools in our toolbox in order to help our cases. I would say chiropractic is one of the tools, but it's not the main tool. It's just one of many, and it's how we're strategically applying these things to help our patients.
Yeah, that's really cool. So, how, I assume that, I know you and Lauren have talked, so this may be old news. Whenever you do have a patient that has POTS or another type of dysautonomia, what are the things y'all normally look for first, or kind of the first resort on how to help treat that?
Yeah. So as you guys know, and for maybe people who don't know, POTS is neurological, or POTS being a dysautonomia is a neurological condition. Obviously, it affects the cardiac system, which is why kind of the first point of contact is that cardiologist, which, okay, that makes sense, but it's stemming from a neurological dysfunction. The brain isn't operating the way the brain should be operating, and it's not controlling blood pressure, heart rate, oxygenation, blood flow, simple terms of that autonomics, but at baseline, it's not controlling it properly. So we need to understand why, what is going on in the brain for that to happen. And we know where in the brain the autonomics begin. We know where they start. We know, obviously, what end organs they affect. And our exam includes obviously bilateral orthostatic vitals or tilt table testing to understand, not just because when someone comes into our office with an example of POTS, it doesn't really tell me much about their brain function. All it tells me is when they stand up, they meet a very specific criteria. But what I want to understand is in real time, or even within the first couple degrees of tilt, what is happening? Is someone actually having a quick vagal response and then having this overshoot with their sympathetics and meeting the criteria for POTS? Is their oxygen dipping at a certain degree? How is their vestibular system functioning? Because that has a very close relationship with the autonomics. How is their visual system functioning? How is their balance system functioning? And we go all through the brain with our testing to basically strip it down to its bare minimum systems and go, why is the brain doing this? And then obviously through that, we discuss the various systems like endocrine, so hormonal components, gut components, thyroid components to their case. And it depends on the case because not everyone shares those same symptoms, but we have to kind of go through the various systems outside the brain that the brain ultimately controls to say, do we need to address this in real time simultaneously with treatment?
Mm-hmm. That's very interesting. Me personally, I have not been to a neurologist yet.
Same here.
Hoping to. But I was sent to the cardiologist first too, and while they were like open and they were even like, hey, you probably want to go see a neurologist about this and this and this, it was very interesting because they definitely don't have the knowledge, I think, that is really required to help this a lot. It's more just like, hey, here's what you can do for your heart-wise, and other than that, just drink a bunch of water and good luck. And so it's great to hear that there is somewhere you can go, for people watching too, if you're trying to figure out what to do, what's the first step? That's something good to know. So, it's not just like all doctors are kind of clueless about it. There are people out there who know.
Yes.
I mean, I remember when I got diagnosed, they were like, okay, you're going to go see a cardiologist, and that's the very first step, and that's what you're going to do. I'm like, and my mom thankfully was with me, and she was like, but shouldn't she see a neurologist? Because the way my POTS manifests is it looks like a seizure. And so she's like, it's probably a neurological, and they're like, no. Like, we would know what it would look like. No way, no how. It's not, no. And then I went to the ER, and they were like, oh, well, you do have POTS, but we're not going to call a neurology consult because the neurologist didn't think that my POTS was real in the ER, because the neurologist was like, you don't have POTS. It's a cardiac issue because you had a hole in your heart when you were a kid. And so they were like, it's just stuff reappearing. And the cardiologist was like, this is not matching your birth history. This is this is not matching, and you need to see a neurologist. But it's very hard. And I'm sure, looking out for like patients and things like that, it's hard to get in there with the neurologist, especially when you have POTS. Because I was calling yesterday to like 8 different places. You have to have a referral, or it's a 6 to year-long wait to get in with some neurologist now just for POTS. That's not even including if you have another, kind of disorder. It's just for POTS alone because of the rise and uptick in POTS just in America in total. But I feel like this is another question I was going to ask. Do you have any male patients? Because I know, like, research-wise, okay, so I mean, they're research-wise, they talk about, primarily in women, that's where POTS has been seen. And so could you just...
I'm also going to say dysautonomia.
Yeah, dysautonomia.
Because what's happening is everyone's getting diagnosed with POTS, or that's the first thing we're thinking of. And sometimes, like, especially the males, they may not meet that full criteria, and they may be exhibiting more of an autonomic dysfunction or other sorts of dysautonomias. But yes, we've had male patients in the office with POTS, hyperadrenergic POTS, other forms of dysautonomia like vasovagal or neurocardiogenic syncope. Yeah, it's definitely affecting women more and then male counterparts. And also, I mean, we know through research, men tend to not seek medical attention as quickly as females. So, kind of the question is, I do see it obviously much more in females, so that is correct. But also, are men not seeking that care? I think that is also a factor at play.
Mm-hmm. What do you feel like is kind of the biggest warning sign that you get when patients come in and start describing, what's going on, what's happening with them? What's the biggest sign that it's probably some sort of form of dysautonomia?
That's a good one. One of the biggest. I mean, the usual symptoms, the common symptoms, I should say. The common symptoms, obviously, lightheadedness, dizziness, stuff of that nature. But what I also ask my patients is like, do you experience any unexplained anxiety? Unexplained. Like, you're chilling on the couch or you're hanging out with friends, nothing's really happening, and all of a sudden your body feels like it's going through anxiety. Now, that doesn't always point to autonomics. That can point to a lot of other things in addition to that. But that is something that I like to ask my patients quite a bit. And, sometimes we kind of split both the psych and the body just for a second there. And we go, okay, do we have a pre-existing with anxiety diagnosed? Okay. But they know their anxiety to an extent. Do you feel it in your body and you're just hanging out? Nothing's going on. Nothing's stressing you out. There's no other additional factors at play. Yes or no. That's something that I find is very common with my patients. They'll say, well, yeah, I was just told I had anxiety.
Mm-hmm.
Like, ooh, okay. But can we take that diagnosis and actually understand it as a symptom? Not just a diagnosis and write off and go, okay, well, you faint, so you must have anxiety. It's like, well, no. Let's look at it as a symptom and understand why that's happening. So that's definitely one that gets kind of tossed under the rug kind of quickly. Migraine, just those common symptoms, and sometimes people haven't seen a provider yet and haven't been able to piece those symptoms together. Long history of gut dysfunction. So not going to the bathroom. This is so important. I always tell people that their body starts to whisper at them and then it will yell. So those small whispers, like constipation, right? Because the vagus nerve isn't working well, the autonomics aren't shunting blood to the gut, we're not voiding food or voiding stool correctly. History of acid reflux, history of bloating. So some of those smaller symptoms that we kind of write off, I didn't eat well, or, I just got to take some Metamucil and move on, or I need to do X, Y, and Z. And it's like, well, if that's still reoccurring, the problem's not the lack of Metamucil, there's a problem happening. And now, do I say that every person in the world who's constipated has dysautonomia? No. But what that means is the body's whispering. Lack of sleep, inability to sleep, inability to fall asleep, inability to feel recovered, afternoon crashes, or opposite, they're getting energy before bed. These are small ways that the body whispers to you and it says, something's not quite right here. Now, does it mean all these symptoms point to dysautonomia or POTS? No, they're commonly seen with them, but it's because the brain has so many hands and so many different systems that you're going to get involvement of multiple systems through the body. But I tell my patients at some point, the body screams. And that's when we're super lightheaded, we're knocked down or passing out or whatever the person is dealing with their condition, we're halt to a stop. And they're like, this popped out of nowhere. And I'm like, did it? Let's go back. So during our exam, to kind of piggyback the last question, we go retroactive with our patients. let's talk about life before this diagnosis or life after. Sometimes I have patients who are like, I passed out one day randomly, and that was the start of it. So it's like, okay, well, let's talk about life before that moment and let's understand, was there anything else kind of whispering at you? And then obviously we're at this point and then we move forward.
Yeah, I think that's honestly so interesting because Lauren, I think we talked about this in the first episode, was both of us in the past have been told so many times, you have anxiety, this is how you can help, blah, blah, blah. And, I was like, yeah, there's no doubt I have anxiety, but I really was doubting the fact that I was being told, yeah, these are panic attacks. I can literally be saying in my mind, there's nothing to be anxious about. Why are you acting this way? And so it's really interesting that you bring that up because I'm sure there are so many other people dealing with the same thing, whether they know they have POTS already or not. And I wish that more people would have been open-minded as to share that information earlier on, instead of me just thinking like, oh, there's no fixing this. I'm just like anxious about nothing forever. And, all these symptoms come along with it. And so now finding out that all of that is from kind of a different root cause is just very interesting.
I mean, I think one of the other things that also isn't talked about a lot, which I've been doing research on, is the vagus nerve, which you've mentioned like a bunch. And like my parents like have, if I could pull out the books of how many books they have on the vagus nerve since I was like 4, they have like over 10 books, and I work with like a vagus nerve specialist, all of the stuff. But not a lot of people know what the vagus nerve is and how it is also connected with this dysautonomia and POTS. So if you could just take a second to kind of explain the vagus nerve, how it works, and how it's all interconnected, that would be great.
So, not getting too technical for everyone, but your part of your brain is called your hypothalamus, and your hypothalamus is a very interesting part. It regulates hormones, it regulates adrenal function, it regulates body temperature, it regulates your autonomics, and a lot of other things. We can sit all day and just talk about that one piece of the brain. But what it does is it sends projections down into our brainstem. And this is the part where our big wrinkly thing that we think about, that's our cortex, comes in, brainstem, and then we go into the spinal cord. So your hypothalamus sends projections down into that brainstem. The vagus nerve is a really hot topic right now because of where it's located in the brainstem. So you can split the brainstem into kind of 3 parts: the midbrain, the pons, and then the medulla. The midbrain tends to upregulate the sympathetic nervous system, and the pons and medulla tend to upregulate the parasympathetics. And the lower down, closer to the medulla, the more parasympathetic activation. Your vagus nerve comes out in the medulla. So when everyone is the hot topic of vagus nerve right now is because the thought about dysautonomia is, well, we're sitting in a dominant sympathetic state and we need to upregulate the parasympathetics. So let's address the vagus nerve. And they call it vagus because it comes out of the brainstem, it comes out of the spinal cord, out of the spine, and it wanders. And it's called the vagus nerve because it wanders. And it wanders through basically our chest and our abdomen, which is why it helps to regulate peristalsis and regulate other visceral things that happen in the body, such as digestion and cardiac. But what most people don't know about the vagus nerve is it's actually 80% sensory and only 20% motor. So what this means is it takes your environment and it brings information up to the brain at an 80% of it, and only 20% of that function of that nerve is information going down to the gut or down to the heart or down all throughout the cavity. So the environment in which we keep our gut or keep our digestion directly impacts brain function, which again is a whole other conversation, maybe for another time. But that is why vagus nerve gets so much. It's a hot topic right now. And it is definitely something we utilize in the office. We do vagal nerve stimulation. We teach our patients how to do it. It's not the end all be all. There's a lot more that needs to happen because not every POTS patient has problems with the lower end of their brainstem. So that's the uniqueness about what we're doing and what we're seeing is we can't just kind of run these individuals through a people mill and go, hey, well, since you have this diagnosis, you're going to do the exact same treatment as the next patient, as the next patient, as the next patient. Everyone has a different nervous system. Everyone has a different function of that nervous system, and we need to understand where in the brain this is. So that's why, and I'll hear commonly, well, I've done vagal nerve stimulation and I've seen some improvement and it plateaus. Or I didn't see any improvement sometimes. Or some people like really do well with it. And that's okay. That means that the person who did really well with it, that's where most of their dysfunction likely is. For the other individuals who are kind of plateauing with it or not doing as great with it, it means that the dysfunction is elsewhere. So you're not getting right where your brain needs that stimulation to create neuroplasticity and to change its function. So those are that's why we have our exam, and that's why we take that individual approach for our patients.
That's amazing how you can like really find all of that out.
Mm-hmm. Yeah, definitely.
Did you want to ask the next question, Tori? Did you want me to?
Are you going in order?
Not really. I'm kind of just like sporadically going through them.
I'm kind of doing the same thing. You can go ahead, Lauren.
Okay. I think the next question that I had was like, you talk about working with like specifically functional medicine and things like that. So kind of how does that play a part, but also in a holistic way? Because a lot of the times it's sort of just like, okay, like you have dysautonomia, you have POTS, whatever it is. Here's like a drug over the counter, whatever it's called, and like you take that. And like Tori and I have two completely different experiences of, I know she's on medication, not on medication. And so just kind of how is the differing between, working with functional medicine, but also combining a holistic sort of environment in the office together, working with dysautonomia.
Yeah. So like I talked about that hypothalamus. So this part of your brain has a direct access with your thyroid, a direct access with your gut, a direct access with your ovaries or testicles, a direct access with your adrenals. So when one axis becomes off-kiltered, the rest can also get off-kiltered as well. Your brain has its hands in so many different systems. Doesn't mean every single system's going haywire, but it means that it needs to be evaluated, and we start everything with like a very in-depth history and a very in-depth understanding of people's symptoms to say, does this person have an adrenal component or a thyroid component or a gut component that we also need to do? And why this is so important is because your brain requires three things in order to change its function. It needs ample amounts of oxygen, which obviously with the dysautonomia, blood flow is a big concern, right? So that's already one barrier, possibly. That's why we have to address it. Fuel in the form of glucose or ketones, depending on your diet, but also depending on your adrenal function and depending on your thyroid function, how well is that fuel getting around? And then you need stimulation, which is like the rehab component. So the thing is, we're doing the rehab in the office, but we're also addressing other systems that for that patient need to be addressed first and foremost, so that the brain is getting ample fuel back to it, and then it can change its function better. But also, like I talked about that vagus nerve, right? 80% sensory. So if someone has long-standing gut issues, let's say they have infections, that brain function is not going to change very quickly because the brain is inflamed. It's not getting good fuel or whatever the scenario may be. If someone has adrenal problems, not just hyperadrenergic POTS, but I often see a lot of POTS patients, they may not meet the criteria for a hyperadrenergic presentation, but they still have adrenal problems, like waking up in the middle of the night, 1 to 3 a.m., crashing through the day, energy at night, slow to get up in the morning. These are actually not just POTS symptoms, they are indicative of adrenal problems. So that's also something that happens as people get diagnosed with this condition, and they're like, well, it's because you have POTS. That's why you're like this. And it's like, well, no, not always. I have POTS patients who don't suffer from waking up in the middle of the night, or people who aren't crashing or having reverse sleep patterns. But I also have a lot of patients who do, right? So that's where we have to really get nitty gritty and really look at this person holistically and understand, what is their sleep like? What's their stress levels? What does their life look like? Is there something going on with their adrenals, their thyroid, and go kind of down the list with them to say, okay, maybe A, B, and C are really good, but D and F need some work. So to kind of answer your question, we work synergistically with other practitioners like medical cardiologists, medical neurologists, and that's fine. But also we're addressing these additional systems to help them. For some patients, we're able to help them off medications. For some patients, they're actually able to do so much better on their medication. So it really depends on their chemistry, depends on their goals, it depends on a lot of things. So in our practice, we look at the brain, and that is the big part of what we do. you can't look at the brain without it looking at the rest of the body because it has its hands all through it. But you have to target both simultaneously to able to improve someone's functionality and actually get them to where they want to be.
I think that's honestly so interesting because, I would have never thought, like, there's just so many different root causes. There's so many different parts of your brain that could be affecting it. So, kind of going into this next question that kind of affects it, I know. So I know there's different things you can do depending on where in the brain all of this is happening.
Yeah.
But for the most part, what are kind of the key lifestyle changes that you highly recommend to people coming in with POTS or other forms of dysautonomia?
Yeah. It would range a little bit on the type of dysautonomia, but for POTS, so first, I find everyone kind of gets told, well, just drink 100 ounces of water and drink X amount of salt. And and we see this throughout our office, but I had a case where I had they were a very small individual. They were just tiny, and they're drinking 100 ounces of water a day. And I was like, you're dehydrating yourself. And we couldn't keep their blood pressure up. And so I was like, you actually need to drink less water and change your ratio to your electrolytes for your blood volume, for your weight, for your size. And also, they were super healthy. They were like, I'm going to eat all the fruits. I'm going to eat all the vegetables. They were eating so much water. So they were also consuming ounces and ounces of water through their diet, and that wasn't addressed. And their blood pressure was so low, so of course their heart rate has to come up to work and compensate to get blood flow up to their brain. And I was like, you actually need to drink a little less water, and you need to change your electrolytes X, Y, and Z. And I was like, not saying to bring down the fruits and vegetables, but we got to also get you some salt in through here or stuff like that. So what I want people to know is it's not a one-size-fits-all with this condition. It really isn't. And this is like the important part of working with a provider that understands that, to say, okay, like this is actually the amount of water that I need to be drinking. This is how much electrolytes I should be drinking with my water. And then, given also what are you consuming through the day? Because that's going to play a big role. Because if you're eating a lot of crackers and salts and things in packages, they're more dehydrated. But if you're eating a lot of fruits and veggies and even meats, they have more water. So that's going to directly impact that. So I don't want to give a very specific suggestion because it is so different between cases, but I want people to know that sometimes that 100 ounces, a ton of salt off the bat it can help quite a bit. But if you're the individual who's like, I'm doing my salt, I'm doing my water, and I'm not feeling any relief whatsoever, we gotta reevaluate what we're doing. In addition, something that I see in our practice, we see is blood sugar fluctuations with POTS or dysautonomias. And that what happens is their blood sugar drops and their cortisol has to go up, because your cortisol keeps your blood sugar stable when you're not eating or when your blood sugar dips too low. But what that looks like to a POTS patient or a dysautonomia patient is a stress response. That body anxiety that we kind of talked about at the beginning, cortisol being high will cause, tachycardia. It will cause sweating. It will cause nausea. It will cause heat flashes. It will cause these various things. And if cortisol is not enough, then we're getting into adrenaline to do the same thing. But I always tell my patients, well, we can't sit here and control our cortisol. Like I can't sit here and be like, okay, cortisol, I need you to come up now. But we can control our blood sugar. And so I like to really help with that for patients and I got to meet them where they're at. That's the most important thing, because if someone is extremely nauseous or if they can't eat ample amounts of protein, that tells me there's something going on with their digestion. So again, how we talked about like the multiple factors at play, that tells me, okay, we might need some digestive support first before we're really targeting that blood sugar and we kind of roll out a plan. But balancing blood sugar, so getting good amounts of complete proteins, fats, and complex carbs. If someone is extremely tired and they're sleeping 10, 12 hours, or they're in a flare, they're sleeping 10, 12 hours, like we have to make sure we are eating enough before going into that fast, because that's what happens at night, and breaking the fast appropriately in the morning. So those are things to look out for to help stabilize blood sugar. Smaller meals are easier on the digestion, easier on the brain to break down. So I tend to say smaller meals are going to be where it's at for my dysautonomia POTS patients. Frequent meals, and if they have any activity, like I have some POTS patients who are athletes, some POTS patients who are active, well, then we stack simple carbs around their activity and we balance with complex carbs throughout the day. So those are just like some examples to start. Circadian rhythm is very important because that's going to help that cortisol rhythm and help their energy through the day. And I don't want to get too nitty gritty in all of this, but helping people get up and wake up or go to bed at the same time each day. Now this gets hard depending, like if that's difficult to obtain, then we're dealing with dysfunction of the brain and we're dealing with a cortisol problem. So this is why this gets so intricate so quickly. And it's not just, well, you have dysautonomia or because you have POTS, that's why. Nope. There's more to it. That makes sense?
Yeah.
Cool. Yeah. So it's like really what I want to hit home is it's so not a one size fit all. And it like working with providers that understand that actually look at you. And I tell my patients, I look at you like you don't have the diagnosis. Okay? I look at you like you are a person. Now, the diagnosis, it's there. Definitely keeping in mind with that. And especially, but I'm treating you. I'm treating you as you are today, as you are in front of me, as a whole entire human being. You're not just a brain, or you're not just, low blood pressure, or you're not just some gut problems. You are an entire human being, and that's how it should be addressed.
Yeah, I have like no words because all of that was just like amazing.
I love what I do and I love working with dysautonomia cases because we really combine that functional medicine component and especially the neurology. And our premise at Carolina Functional Neurology Center is like, you can't look at one without the other. Like it just doesn't make a whole lot of sense. And that doesn't mean, if I have patients who have functional medicine practitioners already on their team, great. Then I can just focus on the neuro. Like it is a team effort, and it's a team effort with their neurologist or a team effort with their cardiologist. It's a team. And we got to support the patients fully with that.
Mm-hmm.
Yeah.
Lauren, did you want to ask the next question?
Yeah, I was gonna ask. So a lot of people think that POTS is a cardiac condition, point blank. Like everybody's just like, that's what it is because it's your heart rate going up. And like even when I tell my friends like I'm gonna pass out, they're like, and they my friends even bought a pulse ox. They're like, oh, your heart rate's up. I'm like, yeah, my heart rate's up, but that's all it is. And I was like conditioned with my POTS that it's a heart condition. And now that I've been in the diagnosed stage for almost a year now, now I have my primary care physicians being like, this isn't just your heart, Lauren. This isn't just your heart. What else could it be? And I'm like, I don't know. So I mean, for people that think it is just a cardiac disorder, how can we then define the fact of, okay, this isn't just a cardiac disorder? How is it then connected with the brain, and kind of how is it more of a neurological issue than what I feel like doctors may be, not really focusing in on?
Yeah, I mean, so if you were to, so your heart has its own nervous system to it, right? It has its own electrical system. If you were to take your heart out of your chest and let it beat without a brain, it beats at 100 beats per minute. Okay. Now, given someone without POTS or IST or what may have you, the average person's heart rate does not beat at 100 beats per minute. Like just laying there, just chilling. Obviously, if you're doing other stuff, different. But you don't typically beat at that rate. Why that is because you always have descending inhibition from the brain. So that means top down from the brain to the heart, telling the brain's telling the heart, all right, slow down. That's always happening. That's always happening throughout our day. Now, that's why, I mean, it looks like a cardiac condition. Heart rate's going up, blood pressure's doing something else, we're not feeling good, we're getting lightheaded, all those things. But your brain constantly has bottom down approach onto the heart and to your circulation, so the rest of your body, to manage that and always and help you adjust to your and adapt to your surroundings versus standing up, walking, running, working out, or lying down. You always have descending pathways from the brain down controlling it. And so where the autonomics begin, like we talked about that brainstem and that hypothalamus, and it goes out. So it begins there and it innervates like saliva glands and your eyes and all those things, which is why people have such an array of symptoms and various symptoms as well. So I always call this, it's a multi-symptom condition, but it is neurological at its core. That's where the dysfunction stems from. And it's how the brain's communicating to the heart. It's not communicating correctly.
I mean, specifically, like, with that, I don't think a lot of people understand, like, oh, it's your brain. Because, like, I talk about, with, like, my friends, they're like, you don't look good. I'm like, yeah, because I'm talking to myself to try to figure out what's going on. Like, because I'm like, something's not, like, something's misfiring.
Yeah.
And it always feels like it does. And, people don't talk about that. Like, people will clutch their chest about, or talk about how tight their head is. But I have, friends that I go to school with that are like, hey, like, I was talking to myself and, like, I felt something completely go off and then everything went black. And I'm like, maybe it's a, neurological thing. But you never really know, because I feel like also with POTS, it is still, like, such in the early stages of, like, people not understanding, but it's also been around for a long time. Is it just sort of becoming, I guess, not a trend, but, like, more around, I guess, because it's post-pandemic, post-COVID?
It's definitely gained a lot of traction since then. So dysautonomia, or even like a long haulers presentation, is not something that's foreign to the functional neurology realm, because I've seen long haulers from other viruses as an example, or other sorts of conditions. As an example, people can develop dysautonomia from concussions, right? So post-concussive dysautonomia, right? So these are things that we have known as a community or as a profession. We know this. So we are familiar with autonomics. We're familiar with the various things that can trigger it. Obviously, there's only so many different providers in the US that do what we do. There's very little, because it is a newer profession. But what that means is it has gained this traction, obviously, given the light of the pandemic. And so we are seeing more and more people develop dysautonomia, or they had kind of these like off symptoms. They're like, yeah, I used to pass out when I was younger. And I'm like, that's not normal. But they're like, yeah, I used to pass out like once a year, or like only when I was really stressed. And my doctor my favorite one is, my doctor just said it's because I'm a girl. And I was like, oh yeah. I was like, I don't, no. But they, they'll say I have these little symptoms, and then all of a sudden they got COVID, or they had a concussion or trauma of any sort, whether it be emotional, physical, and then we're in this full condition. So like I said, body whispers until it yells, right? So I think there's a lot of factors that have played over the last couple of years with this pandemic, but what is a positive out of this is that people aren't taking 10 years to get a diagnosis anymore, or like 8 to 10 years. Now people are getting this diagnosis and they're able to get proper management and start kind of taking matters in their own hands and realizing there's practitioners out there that can give them that individualized treatment. So that's good. I think that's like one slight positive out of this. But yeah, to your point, it is a neurological condition. And it has definitely grown with attention over the last few years. And I think that we're just going to kind of continue in that movement where more research is going to be done, more treatment strategies are going to be done. All of that's going to fall into place for individuals to get help.
Yeah. It's funny that you mentioned it's because you're a girl thing. So I think we've talked about that like every episode. I think the medical gaslighting is like a canon event for POTS patients. Like, you're going to go somewhere and they're going to be like, are you sure you're not pregnant? You know, which there's questions where it's like, yeah, you want to ask that, but it's always like, well, you know, you're probably just tripping. It's probably like your period or something.
Yeah.
Or are you stressed?
But still, like, you know, even, sorry, back to like the first question, you're like, what are some symptoms? Like, horrible periods are not normal. Like,
Mm-hmm.
I have a lot of soapboxes about these things. I'll prevent from stepping on them, but you know, I'll just like not step on them. But women are told like, yeah, you go through this once a month and it's absolutely terrible. I'm like, no, actually, that's common. That's not normal. There's a very big difference, and I tell my patients all the time, like, common does not equal normal.
Mm-hmm.
And like, they're like, it's your cycle and you passed out. It's because you lost a lot of blood. It's like, no, that's not what's happening. You know what I mean? So yeah, I love that you brought that up. That might be for another time, but
yeah, I've had doctors who are like, oh, like I've gone in, and of course because of the color of my skin, they're like, oh, so you're pregnant, and like, and you're just exhibiting like pregnancy symptoms, and I'm like, I have my doctor's note that says I have POTS. It's right here. And like, this doctor works in this hospital that like I go to the hospital where my team is at. I'm like, this doctor works in this hospital. And I was diagnosed by this doctor who says I have POTS. They're like, no. I'm like, that makes no sense. I'm like, I have the diagnosis. And then they're like, oh, but your pregnancy test was negative. And I'm like, really? I wonder why. like, are you shot? And it's just such an interesting thing, I feel like, specifically with women that have, you know, dysautonomia, POTS, and we go to the emergency room, even though, like, also when you go to the emergency room and you have dysautonomia, they can't do anything. That's the worst part about it. Because a lot of people go to the hospital and they're like, oh, like, I'm gonna get better, but because there's and I've, you know, that was the first thing my doctors told me. They were like, you know, don't rush to the hospital unless your heart rate is like above 100 and, you know, blah 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 blah.
yeah.
And like, but that is the only time you're supposed to go. Like, my heart rate when I was sick with COVID and strep last year hit 237, and I had a fever of like 100 and I think 5, and I went to the hospital and they were like, oh, you're fine. I was like, I have the shakes. Was like, my heart rate's 200 and something, I have the shakes, and like, it's not, you know, it's not good. And I think there are also some you know, common things with, like, for example, getting sick. Like, when you have dysautonomia, you get sick, you kind of can't control it either. And so are there like warning signs when, you know, that you possibly see in patients of, like, you know, if you feel like, hey, like, your body's telling you like this, like, you're possibly getting sick, or, you know, there's something coming, that you notice?
Yeah, I mean, I've seen that in practice where, you know, we're kind of in the midst of treatment, and I kind of understand like where their heart rate typically sits, what it's doing when standing, and obviously we're doing treatment so that in real time, that when they do stand up, we're not having this large swing anymore. Like, we're doing things to change this in real time. And then, like, from one appointment to the next, like, resting heart rate was, you know, 65, and they stood up and were attenuating that response, and it's going great. Next appointment, resting heart rate's 98. And it's like, and they don't have symptoms. They're not expressing any symptoms of illness. And I'm like, that's weird. And, you know, that's a little different. Your autonomics will respond faster than you feel like your prodromal symptom, which is like, oh, I have a little sore throat, or starting to feel fatigued, or I'm starting to feel that like I'm coming down with something. And so your autonomics tend to respond quicker. However, when you're in the midst of it, we don't want to be like ridiculously hypervigilant on like our system at all times, because obviously we don't want to create any additional stress. Like, what's my heart rate doing now? What's my heart rate doing now? But knowing kind of where you sit is helpful. And then you can kind of see like, well, I was around, or I was traveling, I was around a lot of people who were sick. You can kind of see it in real time. Your heart rate starts to respond a little differently. That might be some signs that your your nervous system is starting to activate your immune function, or like your immune system and your brain are starting to get activated, because they work together. They help each other. I call them the old married couple. Like, they're never gonna not be apart from one another. So it's really neat. Sometimes sensors like Whoop as an example. I'm not saying anyone needs to get a Whoop by any stretch, but I was listening to a podcast, and it was during like the pandemic, and a person came on this podcast and was like, yeah, my Whoop told me I had symptoms before I did. Like my body temperature was up a couple degrees, my resting heart rate was elevated, my breathing rate was down, and then 2 days later, the person got COVID or had the first symptom of COVID. But actually, the body was responding 2 days before that or even sooner. So the autonomics respond faster than you feel it. So I've seen that clinically. The patient will come, send me an email and say, yeah, I had a UTI, or I got sick, or I got the stomach flu, or whatever it was. And I'm like, well, that makes sense why your autonomics were doing that. And then obviously as they're recovering from that, you can see the differences too.
That's crazy.
Mm-hmm.
It's very, very interesting.
Yeah. The brain is super cool. In my opinion, it's the coolest organ that we have. So
it is.
Yeah, that's awesome.
Well, Lauren, did you want to ask one more question before we wrap it up?
I know, yeah. I think I wanted to ask like one more question, and I think it was, as we're getting into more like the future of medicine, and as, years and years are sort of progressing forward, what are some of the things that I think you're looking forward to, or stuff that you wish you could see integrated sort of into the medicine world?
Oh, this is awesome. I would love to see the functional community and the medical community team up. I mean, I don't know how long of a road that's going to be, but I hope that we start to utilize each other more, because I think that both communities have such a powerful role in healthcare, and it kind of works on two axes. One's more of a prevention, and some of it's more sick care, like more reactionary, which you need both, like to address the body. And I think that we could really come together to provide better prevention and better reaction and work simultaneously. So, I mean, that would be a great dream of mine, to see that, especially with dysautonomia. I mean, I'm understanding research is trying to uncover, especially a genetic component to this condition. And I think we're getting closer and closer to it because we're seeing it appear in families. We're seeing it being triggered by very specific things like concussions or viruses or illnesses or trauma, which we see this similarly in autoimmune conditions, or we see this similarly in migraines, which we know there's a genetic component to those conditions. And so what I think research is kind of trying to point into that is to go, is there a genetic predisposition that is at play? And I'm hoping that's what we're going to begin to uncover. And that would be a very cool advancement about that. But also, I always tell my patients, like, especially the ones with like autoimmune disease that have that genetic component, they have the genes have turned on, and they start producing the proteins and then creating the condition. Diet, lifestyle, mental health, everything keeps those genes from being turned on. Now, it depends on the person. It depends on a lot of other factors. That's a very simple way of putting it. But something starts these genes to start producing, right? If they haven't been turned on. Something starts them, they turn on, and then they start producing. So what we're seeing is these conditions like concussions, or some people will report getting dysautonomia after a traumatic event, they will start developing their condition. So wondering how we can work preventatively. If that's what we end up finding out, can we start working with that? Can we start giving people more resources, more education, so that, okay, well, if you have these genes, we can keep them at bay and kind of prevent this condition to start, like push it off as much as we can. Right. That'd be the dream. That's if there's a genetic component to this. Right. So I think that's what research is trying to uncover. And that's where, with conditions that we're finding genetic components, that's where their research is going into. So if that is uncovered with dysautonomia, that can also go in that direction. So yeah, those would be like my two biggest things is let's understand if there's a genetic component, and then also I would love to see the functional world and the medical world come together and work together. And like, it's already beginning. I work with cardiologists, I work with neurologists, I work with gastroenterologists, I work with integrative MDs, I work with internists every single day of practice. And we have one common goal, and that is to help our patient. And so it's already starting. So that's really exciting.
Yeah, I love that. I would absolutely love that too. Anything to help and help us understand our condition more.
Yeah. And with treatment, like we give our patients tools in order to, depends on the case, but as an example, if someone does have a very high heart rate, we give them tools in order to lower their heart rate naturally, not through a pill, not through a supplement, through specific rehab. They can lower their heart rate in real time. So imagine, obviously, if in your scenario with being sick and heart rate's up to 237, you can do stuff in real time in order to stabilize that nervous system reaction and stabilize your nervous system in general. And with treatment, we've seen patients that doesn't happen anymore when they get sick, especially like those post-COVID cases, those long hauler cases where they're, extremely scared to get sick again, because that's what kind of, put this into a catalyst and really started their journey. They get sick again after treatment and they're like, I didn't have any issues. It's like, that's what I want. It's not a matter of, if you get sick, it's just a matter of when, right? So those are, and also that's addressing gut, that's addressing immune function, that's addressing all of the various systems, including the brain. So I think that's like the biggest thing that's getting missed is the brain. We have to address the brain.
Yeah.
Awesome.
Well, Lauren, I guess, would you like to wrap us up?
Yeah, this was an amazing episode. I am so amazed. I'm just like amazed. I've just been like sitting here just like amazed at like how much information I've gotten and like how much this is definitely gonna help my research. Into looking.
Lauren knows a lot too. She does a lot more research than me. She'll be like, oh, by the way, like this is what you're going through, and I'm like, oh, thanks.
Yeah. Well, granted, when you have a parent that like did all of the research and comes to all of your doctor's appointments, like kind of helps when they're sending the articles for you. So
So that's awesome.
Yeah.
I love that. It's like empowerment, right?
Very. Yeah. Very, very empowering.
Yeah.
But where can people find you? Because I know that like people are probably going to want to like talk to you more and like find out, how can they, learn more about what you do.
Yeah. So, I mean, we have three different, to start, we have three different platforms on Instagram. So Carolina Functional Neurology Center. We are Dysautonomia doctors. And then we also just launched something called the Virtual Lab, which is where we're going a little bit more into that functional medicine side, a little bit heavier into that. But you can reach us at all of those platforms. We are the doctors behind that. And then at our website, carolinafnc.com, you can always reach out to us through that. So we try to make ourselves available, and obviously we offer consultations for patients. We do intensive treatments. So we see patients all around the U.S. and all around the world. We've had patients fly from different continents to come and be treated and receive treatment from us. And so the biggest thing is, please feel free to reach out and know that there are treatment options available, and functionality and improvement is an option. Like, it's there. And like there is a way to accomplish that. And so we're here to help.
Amazing. Thank you so much for joining us today, and hopefully everybody will get a chance to listen to this episode. And thanks guys for joining. Bye.
Thanks for having me.